Hi everybody, welcome to Dr Manny's YouTube Learn Shops. This is Pediatric Life Support Part 1, the basics, basic life support. In this Learn Shop we're going to review cardiac and respiratory physiology, respiratory failure shock, basic life support, the CAB sequence, 1 and 2 rescuer, CPR rescue techniques, and the CPR sequence. Now, cardiac is heart. The heart is a muscular organ located in the midline of the thoracic cavity. It's a pump, and it beats at a rate every minute depending on your age. In an infant, 12 months, 100 to 160 beats per minute. Toddler, 1 to 3 years of age, 90 to 150 beats per minute. Preschooler, 3 to 5 years of age, 180 to 140 beats per minute. A child, 5 to 12 years of age, 70 to 120 beats per minute. But this depends, it's variable. Now, the heart receives deoxygenated blood from the body, recycles it in the lungs, and then supplies reoxygenated blood to the body to meet metabolic requirements. That's its function. Now, normal cardiac location, the apex is located in the fifth intercostal space in the midclavicular line. The base is located in the second intercostal space, substernally beneath the sternum or breastbone. Now, remember, the heart is totally dependent on oxygen and high energy phosphates for normal function. No oxygen, no pumping, arrest. Decreased oxygen, ineffective pumping, problem. Now, in an example, a pediatric that weighs, let's say, 5 kilograms has a normal cardiac output to meet metabolic requirements, which essentially is about 400 mils per minute, which means 80 mils per kg. If we look at the normal distribution of that cardiac output, the brain receives 60 mils per minute, that's 15%. The heart receives 20 mils per minute, that's 5%. The lungs, 2%, skin, 10%, kidneys, 25%, liver, 30%, skeletal muscles and other organs, 13%. In total, 100%, 400 mils per minute. When the pediatric goes into cardiopulmonary arrest and you're providing effective external cardiac compressions, they are only receiving 10 to 15% of normal cardiac output. That's when you're doing it at expert level, effective external cardiac compressions, which means 80 mils per minute or 1 mil per kg per minute. Only 10 to 15% of normal cardiac output if you're doing it really well. So the distribution then of cardiac output with effective CPR is the brain's only receiving 16 mils per minute. Heart's only receiving 4 mils per minute. The total effective cardiac output with effective CPR is 80 mils per minute. Now, when we look at the lungs, the respiratory tract consists of the mouth, nose, trachea, bronchi, bronchioles, and alveoli. Their main function is oxygen and carbon dioxide exchange between alveoli and capillaries. The main organ is the lungs. Other respiratory organs, however, do include the diaphragm and the intercostal muscles. The lungs are normally found in the thorax, the chest, one on each side, right and left. Anteriorly, they extend from the clavicle, apex, to the 6th rib, base. Posteriorly, in the chest, the lungs extend or end at the 10th rib. Now, when we look at the vital signs, it's important to remember the heart or pulse rate is typically 100 to 150 in a resting 1-month-old. 80 to 120 in a toddler or child less than 3 years of age. 60 to 100 in a toddler or a child greater than 3 years of age. Bradycardia, less than 100, less than 80, less than 60, depending on your age group. Tachycardia, greater than 150, greater than 120, greater than 100, depending on the age group. The typical respiratory rate in a 1-month-old infant is typically between 40 and 60 breaths per minute. Less than 3 years of age, 20 to 30. Greater than 3 years of age, 10 to 15. Bradypnea, depending on the age group, which you can review in front of you, less than 40, less than 20, less than 10. Tachypnea, depending on the age group, greater than 60, greater than 30, greater than 15 to 20. Then you've got the blood pressure. A typical blood pressure for a newborn at rest is 60 on 30 millimeters of mercury. In an infant, 70 on 40 millimeters of mercury. From 1 to 10 years of age, it's 90 plus age times 2. If you're looking at hypertension in the newborn, greater than 60, greater than 70, greater than 90 plus age times 2 in a 1 to 10-year-old. If you're looking at hypotension, less than 60, less than 70, and less than 70 plus age times 2. And when we look at cardiopulmonary arrest pathophysiology, it's different in comparison to adults. So if we look at the newly born, the infant, typically they have problems with respiratory insufficiency or shock, which could be SIDS, sudden infant death syndrome, asphyxia, respiratory diseases, airway obstruction, submersion, sepsis, and neurological disease. Then you've got a child. Children, the biggest risk are trauma, injuries, and typically these are motor vehicle accidents, and they're the leading cause of death worldwide. Head injuries, chest injuries, spinal injuries. Now, respiratory insufficiency, how do we recognise it? Well, there's airway obstruction. You can hear them breathing. Inadequate breathing, irregular, slow breathing. Increased work of breathing, use of accessory muscles. Typically, you don't see people breathing. It's quiet, it's unobstructive, there's no work of breathing associated with it at rest. Now, when it comes to foreign body airway obstruction, this is choking. And common causes of choking in the pediatric is trying to swallow large pieces of poorly chewed food, eating while talking, laughing, just eating too fast. Kids are always on the go. Walking, playing, or running with food or objects in the mouth. With a child who's choking, you may alternate between any two of the following methods until the foreign body is expelled. You've got back blows, abdominal thrusts, or chest thrusts. Or just do one of them. Don't let the child choke. Back blows mean placing your arm across the child's chest, bending the child forward and delivering up to 5 firm blows between the shoulder blades. Then you can alternate it with an abdominal thrust, placing your fist just above the umbilicus, the belly button, and giving up to 5 quick inward and upward thrusts. Or you can alternate with a chest thrust. And here you place your fist in the middle of the child's chest, as where you would place your hands for chest compressions, with your thumb facing inward and placing the other hand over the fist, and giving up to 5 chest thrusts by pulling straight back. These are the responsive When you've got choking infants and toddlers, you can alternate between the following three methods until the foreign body is expelled. However, abdominal thrusts are not recommended for infants. And we can class infants as being from birth to 1 year of age. You've got back blows, chest thrusts, and abdominal thrusts. Back blows, place your arm under the infant's chest and torso, support them. Lie the infant forward, head down, and deliver up to 5 firm blows between the shoulder blades. Then you can flip them over. Place 2 fingers in the middle of the child's chest into mammary line, with your fingers pointing straight down, and give up to 5 chest thrusts by pushing straight down 1.5 centimetres. You may observe the foreign body, but do not probe. You can pull the lip open and have a look, but don't stick your finger into the throat. Place your fist for abdominal thrusts just above the umbilicus, the belly button. Give up to 5 quick inward and upward thrusts. When it comes to respiratory failure, how do you recognise it? Well, you have bradypnea, slow breathing, hypoventilation, shallow breathing, and they can be cyanized, the victim. Central and peripheral cyanosis. Central and peripheral cyanosis. Respiratory arrest is basically or simply the absence of breathing and results from respiratory distress and respiratory failure. Bag mask ventilation is an emergency skill that provides oxygenation and ventilation until a more definitive airway can be established by advanced life support providers. Now, when we look at shock, we need to recognise that shock is an important cardiopulmonary arrest feature in paediatrics. And shock is a clinical syndrome that has signs of decreased tissue perfusion. They're cold, pale, clammy, have an increased capillary refill time. Types of shock include hypovolemic, cardiogenic, and distributive. Also neurogenic, but again that's included into distributive. In hypovolemic shock, it can be absolute or relative. There's inadequate intravascular volume, and this may occur because of dehydration, hemorrhage, and third, interstitial spacing. Then you've got cardiogenic shock. This can be absolute or relative as well, and typically results as myocardial pump function. And this may include ischemia, failure, myopathies, or even myocardial infarction. Many pediatrics have congenital heart disease. Then you've got distributive shock. And distributive shock can include septic, anaphylactic, or neurogenic. And this is basically the inappropriate distribution of blood volume. The immediate management for shock includes a brief targeted history, physical assessment, vital signs, oxygen therapy, ventilatory assist, intravenous access, even intraosseous access, and ECG monitoring. The generic management includes, again, a brief targeted history, rapid physical assessment, vital signs, oxygen therapy, intravenous or intraosseous access, hemodynamic monitoring, and fluid replacement. When it comes to fluids, we're talking about crystalloids and blood products, essentially. With crystalloids, we can include Ringer's lactate, which is also known as Hartmann's solution, and normal saline. And this is given at 20 mL per kg at 40 to 60 ml kg boluses, and after which we review effectiveness. Specific management for septic shock includes crystalloids, ringus lactate, Hartmann's solution, normal saline at 60 to 80 mL per kg in the first hour. Then you've got specific management for cardiogenic shock, which could include fluid as well, ringus lactate, Hartmann's, normal saline, but it's given cautiously at 5 to 10 mL per kg, and you monitor the response clinically and with CVP, central venous pressure, and with pulmonary capillary wedge pressure. Blood products, especially in trauma, include packed red blood cells, which is given at 10 to 15 mL per kg, and the effectiveness of the volume is reviewed. When we look at cardiopulmonary arrest, we're looking at the heart and breathing stopping. Step 1. Scene safety is for you, the rescuer, and for the victim, the patient. Look around before you approach. Take 30 seconds to make sure that it's safe. If it's not safe, review your options. Use standard precautions, universal precautions, personal protective equipment, PPE. Use rubber gloves. Protect you and your patient. Step 3. Determine responsiveness. If no response, activate the emergency response system. Get advanced life support. You may be a very effective rescuer, but you need advanced life support to assist you, the victim, transport to the emergency department. Determining responsiveness means take only 5 to 10 seconds, look for signs of life. If they don't look alive, they're not alive. Check the brachial pulse. Take no more than 10 seconds, and this is done for an infant between the shoulder and the elbow. Check the carotid pulse. This is done for a child. Take no more than 10 seconds, and this is checked in the neck, in the groove between the sternocleidomastoid muscle, the neck muscle, and the trachea. No pulse means no circulation. If you can't feel a pulse, there isn't a pulse. Don't waste time. 5 to 10 seconds. Remember, the brain cannot survive without oxygen or glucose. It only takes 3 minutes or thereabouts for the brain without oxygen before irreversible damage could occur.